first of all, I wish you all guys who are now attending this webinar from the bottom of my heart and in the name of Dental Skills Institute, all the best. These challenging times require a lot of patience and endurance. So to shorten it a little bit, we had the idea to start a very little webinar. And I want to show you briefly 5 little tricks out of the magic, what I call the magic box, to apply in the daily practice. And I start immediately now with the presentation. Let's start with one topic that is always, let's say, challenging in the aesthetic area, in the aesthetic zone, is how and where to place an implant in the aesthetic zone, especially in the central incisor zone in the upper jaw. So as we know, of course, we have those fancy tools like CBCT, 3D planning, and surgical guides, but not in every surgical practice these tools are available. So one very easy thing to identify the correct position for a central incisor implant, for instance, is if you take some suture material or some dental floss and you place it around the adjacent teeth. So you can see what we call the Gomez line. The implant should be behind the anterior line. So then you know you're in a safe position where you can place your implant without having trouble with the aesthetic outcome and the restoration of your implant. So that's a very, very easy tool. In addition to that, of course, as we know from all the literatures, and I assume all of the key opinion leaders in implantology have the same attitude towards it, we place the implant a little bit more palatal. So we don't want to force the implant to create too much forces against the buccal plate that might cause on a short and especially on a long-term compromise situation for the buccal plate that is resulting in very bad aesthetics. So how to find some correlation, for instance, with some anatomical structure, for instance, is if we see there is a relation between the canalis incisivus and the direction of the bone where an implant could be placed. So as you can see in these cone beam scans, the direction or the angle of the canalis incisivus is exactly the same where the bone is located to place an implant. And one very easy tool, for instance, is if you place one parallel pin into the canalis incisivus, which is absolutely no trouble for the patient. Yeah, I do believe that sometimes the meaning of this canalis is overestimated. So what we can do is we place a parallel pin of your implant system inside the canalis, and this is giving your direction for an implant, because especially in areas where you have like crooked or tilted tooth angles, it might be a help to identify the right position. But if you do so, you need to know as well that there is an anatomical structure that is underestimated as well. It's called the canalis sinuosus. And the canalis sinuosus, I will show you lately in a 3D image, has a prevalence of 50 to 100% of all patients described in the literature. And it's like located 25 millimeters behind the foramen infraorbitalis. And it reaches exactly the orbital floor and is very, very often in the anterior maxilla palatal area of the canines or the incisivis. So if you have a patient, for instance, where you intend to place an immediate implant in that region, it might occur that your patient is coming back with severe pain issues. And these pain issues, they can even go to the eye or to the cheek region. And if you take a normal X-ray, you won't see nothing. As you can see in this cross section, you can see this canalis is very tiny, and it is behind the root surface of this central incisor. And here on this 3D image, I'm sorry, it might be a little bit blurred, but you can see the thick red infraorbital artery and the infraorbital nerve. And just downwards, you see another accessory artery and nerve and vein channel. This is the structure that I address when you have pain issues, or sometimes like unknown pain issues in patients where you place an immediate implant or a belated implant. And it's important to know that this structure is in many of our patients obvious. So it is something that we need to understand and to identify prior to the implant placement. Here you see another examples on the right side where this canalis sinuosus can be seen. And it's not that it's like super tiny. Sometimes it can be bigger. Sometimes it can be smaller. But we need to know that this structure is prevalent. It might occur that sometimes this canalis sinuosus can imitate a root resorption. As you can see, for instance, in these two slides, it looks like a root resorption, like an internal resorption of this central incisor root, but in fact, it is the canalis sinuosus that is just like overlaying the structure, because it's only 2D imaging that we can take. So you need to know that this structure is prevalent. I've seen, to be frank, pretty scarce conferences that are even dealing with the structure, but it might be in some of our patients, when you place an implant in that region, that they describe massive pain issues and we don't have a clue why. So please address the structure. One big problem is shown in this case report that is done by Olenchek in 2015. You see here, this implant is with the implant tip exactly in the zone of this canalis sinuosus, and the pain issue of this patient was like enormous. So be aware of this structure. To me, it took a while to understand that this is existing in many patients, so we need to address this. What might be the symptoms and what might be a differential diagnosis? Neurofacial pain of the patient is like, can go exactly to the eye region, cheek and nose. Paresthesia is very prevalent in many cases when we touch this anatomical structure, and especially in the affiliated upper lip side. The differential diagnosis is be aware of the psychopatient, of course, or a patient with the massive anxiety issues. So we need to differentiate between the patients that might have like a psychological issue or the ones that have definitely neurofacial pain. Or it might pretend to be an allergic reaction to an implant, let's say titanium implant, or to a bone grafting material when we have used osteosynthesis screws that are like going into this anatomical structure. So we need to be aware that this might be just related to the trauma that we caused during surgery to the structure. How can we prevent this? Please use a CBCT. If you don't have any, refer to a radiologist that can take this picture just to identify the structure and to be sure that you won't do any trauma to this. And of course, use smaller diameter implants in the aesthetic zone. I know 10 years, 15 years ago, it was the opposite. We were told when we place a central incisor implant that the diameter should exceed 4.5 millimeters or even 5 millimeters. This is today completely wrong. We need more bone to create. This is number one. Number two, if we reduce the diameter of our implants, the risk of harming these sensitive anatomical structures is reduced dramatically. According to this very worldwide challenging situation with the pandemic of the SARS coronavirus, I want to address not only to doctors, but as well to us as probably people who might be contaminated with this virus or probably might be treated or where treatment is necessary. I want to address one topic that is, in my opinion, especially in these times, very, very, very important. And this is vitamins. I start and I complete only with 2 vitamins, which I call the 2 major essential ones. And I start with vitamin D. Vitamin D, or 1.225 hydroxy, vitamin D3, is in fact not actually a vitamin. It's a hormone that is going to be converted later into a vitamin. And we know, related to global scientific data we have, that we do have a global deficiency in vitamin D3. And it's not only in those countries where we don't have that much sun exposure, like in Scandinavian countries, for instance. As probably some of you know, I lived and worked there for a couple of years. It's pretty prevalent there, but we do have it in Spain, we do have it in Italy, we do have it in Greece, we do have it in Africa. So for that reason, I want to sensitize you a little bit towards this topic, and not only in these times, but it might help as well in the outcome of your surgeries or implants. If we look on the graph here that you might see, and I have to admit that there is some very differentiated attitude towards what is critical, what is intoxication, what is the proper intake, and what should be like the blood level concentration. This is just one graph. You might find others with different numbers, but I want to show you now this graph. And in this graph, you can see that we talk about a deficiency when we are below 30 nanograms per milliliter. And it is important because we have 2 different values for the measurement of vitamin D3. One is nanogram per milliliter, and one is millimole per liter. And sometimes it's just mixed up. If you have millimole per liter, then you need to divide it through 2.5. Then you have the nanogram per milliliter. So 30 nanograms, or everything that is below this value, we call deficient. And I can assure you, if you would test your patients the next weeks, you would see that it is very, very rare that the majority of your patients would reach 20. And that's a worldwide issue. So in my treatment, I don't do any kind of surgery, no augmentation, no implant placement, whatever, when my patients are deficient in vitamin D3. I want to have my patients at least on 60 nanograms per milliliter, at least, or higher. And you see in the lowest bar that there is 150 nanograms per milliliter that is defined as an intoxication. I've not seen a single study on PubMed or Medline or Cochrane Library that is dealing with a vitamin D3 intoxication. So please, it's very hard to intoxicate if you take normal vitamin D3 doses, which I will explain a little bit later. So what is the benefits of vitamin D3? And these are facts. This is summarized. It's a summary of only a few studies, but it's common knowledge that it's for the oral health super important. It is reducing depression. It is beneficial for oxidative stress. It's very good for autoimmune system and can affect autoimmune diseases. We have data that it's working against multiple sclerosis. It has an antiviral capacity, which is more and more now important in those days of Corona, and even dementia, Alzheimer's disease, and infectious diseases of the respiratory system, is so important to know that vitamin D3 has like an omnipotency factor to our body. The immune system, if you Google not Google, excuse me, if you go on PubMed and you enter immune system and vitamin D3, you will have more than 4,000 publications. You have a lot of time to read, and I can only like motivate you to go into the literature, and you will be thrown away in how many ways vitamin D3 is affecting our body. Actually, there is not a single cell in our body that has not a vitamin D3 receptor. So you can imagine whenever we have a deficiency, and believe me, the majority of you guys that are now attending this webinar is deficient in vitamin D3. We need to take supplements. That's so important. Here's just like some data. We know that approximately 1 billion on this planet has vitamin D3 deficiency, or at least an insufficiency. This is WHO report sources. And we have a prevalence in the adult population in the literature between 14 and 59%. And in the Asian countries, it is even higher. And I'm not a virologist, and I'm not dealing with those very challenging situations as a virologist they are facing today. But we know that this might be a reason why so many Asians have been affected to the virus, because they are pretty low in vitamin D3. But beyond this coronavirus, it is important for our patients as well, because we want to forecast our very predictable surgical protocols and want to achieve very, very good results. We need to maintain high vitamin D3 levels in our patients. And we do have as well studies and data on this as well. So this is just a publication, paper published by Joseph Chukroon. And if you are hearing us, a big hello to you. And Patrick Polacci and Tiziano Testori and Fuad Khoury and George Khoury. It's like a bunch of very experienced doctors who have shown that vitamin D deficiency, and if there's a high cholesterol and a low serum vitamin D, it might affect the outcome of implant osseointegration and might increase the risks of graft infection. So it's super important to address this in our patients, and probably to have a bigger eye on that our patients have a very, very good vitamin D3 level. The next vitamin I want to talk briefly is vitamin C. And vitamin C is important because the question is it better for implants and for bone augmentation if we increase the volume of vitamin C in our patients? And I would say definitely yes, because we do have as well data on this, publications on that we can see here that the wound healing and the bone regeneration is better if our patients have a very good vitamin C level. This is another study that just describes all that is to me important. Vitamin C deficiency results in impaired immunity and higher susceptibility to infections. In turn, infections significantly impact on vitamin C levels due to enhanced inflammation and metabolic requirements. So it is important, and in the last red line, you can see that's even affecting the respiratory and systemic infection. We need to create like good vitamin D3 and vitamin C levels. And here is my personal recommendation. I take vitamin D3 and K2 as a combination. And I would recommend to take at least 10,000 units per day plus 200 micrograms vitamin K2. There is some supplements that are like combi preparates where you don't need to think about K2. These are like combining both. And vitamin C should be at least 1,000 milligrams per day. I take a little bit more. My dosage is I take 20,000 units per day vitamin D3 and 2 grams of vitamin C. We know even in these days of Corona that we have a lot of data that many patients are treated with high dose vitamin C infusions. Here, this is from a Chinese hospital that dealt with a lot of Corona infected patients undergoing severe respiratory diseases. So their dosage was 25 grams in 1 liter of sterile water. No, this is my dosage, but they took 12 grams in a 12 milliliters per hour dosage. Okay, so this is just a paper from New York Post, where you can see that New York hospitals treating coronavirus patients with vitamin C. And on the right side, you can see that it's working very, very efficiently. I try to be on time, so I go a little bit quickly to number 4. Number 4 is I would not recommend to use turbines. As we know, we were taught in dental school, turbine is working very ergonomic, very sufficient in ablation and preparation. But we know as well that the dentin tubules are in a very high amount per square millimeter. We have 40,000 dentin tubules per square millimeter. So when we do a preparation with a turbine, we will open those tubules, and this might expose the odontoblasts with their nerve filaries. So this is why many patients have, after the preparation, some sort of issue regarding pain and sensitivity to temperature. The data we have is pretty old. So this is papers from Erickson in 1966 and Kirschbaum 81 that do explain that 5 to 10% of the prep teeth develop pulp necrosis. And now, if I would say 10%, that would be like 10 out of 100 patients that we cause a necrosis, and this will, of course, turn into a endodontic treatment and a crown and so on. And later we need probably to deal with apical infections. And if we understand that the turbines do work with a high RPM, there is under pressure created that is tearing into the tuberous fluid that is layered with bacteria, with smear layers, with dentin, and all those things that can stay inside the tubules and cause trouble. And of course, we are using sufficient water coolage, but this is something, if you see that the temperature is exceeding 700 to 900 degrees, this is something that is a lot of temperature. So the pathway of a turbine preparation might be, and if we take back the numbers from Kirschbaum, 5 to 10% is we do preparation, then we do need to treat this tooth with root canal treatment, then we have a crown that needs to be placed, and later we have probably additional problems that cause extraction for the teeth. So my recommendation, use a red handpiece, you have better control, you have higher precision. You will see that the patients after preparations with post-prep trauma, like sensitivity, pain issues, is going down dramatically. So this is something I really can recommend. The last little topic is to create a proper flap mobilization for extensious bone graft. So one very, very easy thing is if we create a full flap, like seen in this slide, you see the mucogingival line, like MGL describing this. You need to create like a full flap with releasing incisions on the bone to create a full flap. Once you have this flap in your tweezers, you will find an entry point, a pocket, a pouch, where you can entry a scissor. And when you go now with the scissor inside this pocket, you can use your scissor like a dissecting instrument. You go from one side to the other side, and what you do is you dissect the tissues. You dissect the periosteum from the epiperiosteal connective tissue. This is what all plastic surgeons do when they do like a facelift. So this is so important because this separation of the tissue is causing way less bleeding and way less bruising and swelling the next day. It's not the surgery causing swelling behavior or problems that we do on the bone. It's the soft tissue manipulation. And the more precise we do it, the less will be the trauma for the patient. So once I have separated the tissue, now you can dissect, you can cut the periosteum that is now underlying your scissor, and then you have a very, very mobile flap that is created, and that makes sure that your graft will be covered efficiently. And this is, of course, done previously to any augmentation, because I don't want to manipulate the tissue once I want to close my flap or my surgical site as fast as possible. Another trick is a lingual release, flap release. You see on the slide number 3, this is a lower jaw on the right side, on the left side, excuse me. You have a mid-crest incision, and once you deflect it a little bit, the lingual area, you will see that there is muscles inserting from the musculus mylohyoideus. And you can take now a tweezer, a blunt instrument, and I say you play the violin, you go alongside those muscular fibers that do insert into this flap, and then you can gently tear on this flap, and you will see that you will reach a lot of new volume to cover, even with the lingual flap, your augmentation side. This is my email address. You can find me on Facebook, LinkedIn, and Instagram. And I want to thank you, your DSI skill team, who made it possible for me to do this little presentation. We will have now some time to answer some questions if you want to. And so if there is no questions coming, I go with address that we will have this course hopefully in July in Warsaw. So I hope to see some of you guys there. What I will do, we have some little bonus time. So if I go a little bit into marketing. So one thing is communication. Communication is so important, and I see that so many doctors who are extremely well trained, who have dramatically beautiful skills, do have a problem in communication with their patients, as well as in, let's say, selling their ability to treat their patients on a high level. So it is always the same arguments that I do hear many, many times. It's like, I don't have the right patients to charge more. My dental practice is not in a fancy area, or I can't afford to scare and to lose patients when I raise up my my honorarium. So I do really think it doesn't matter where you are, it doesn't matter in which region you have your clinic. It is just like what we should do is creating values. And creating values is, once you talk about it, you need to take time for your patients. You can charge more. And I did it in not so sophisticated clinics. I did it in very fancy clinics, but we need to find a way how to position yourself. And the last slide probably might explain it. You should attract the right patients, and you should not bargain with your patients. If a patient comes in and I tell him, okay, the first thing that you should do is you should make an appointment for the dental hygienist, and we charge this and this for that. And the patient is arguing, but why it's so expensive? Of course, this is not a patient that I would address for a full oral rehab with veneers or for rehabilitation with 10 implants. So you need to address the right patients, get rid of those where you need to discuss, because it's not the question if the money is there, it's the question, what is the priorities of our patients to spend the money? Number one. Number two, position yourself and be different from the average. I teach a lot in many countries, and I always try to be different from the average in adapting my surgical protocols to the needs of the patients. So one thing is, if you work less traumative, if the syringe injection is not painful because you use very easy tricks, if you have patients that come back the next day after the surgery and that do not complain about bruising or swelling or whatsoever, then you attract more patients. Simple as that. And these patients are very willing to pay more because they have much more life quality after your surgery. My patients, and I'm sure yours as well, they don't want to be kicked out after surgery or after treatment for a couple of days. So many patients can't afford this. It's more expensive probably than the treatment. So we need to address this and to make sure that we treat our patients at so least traumatic as possible. And I've seen many cases where I witness it, that so many doctors don't take time for the first consultation. There is not a second chance for the first impression. If I have a very first consultation, I take at least 1 hour to talk with my patients. And I know there some colleagues tell me, Marcel, but you don't earn money in this hour, and I could do another 5 fillings or do 2 surgeries. I say, yes, for sure. But I mean, if I take my time to explain it, to go through all the alternatives, to explain everything that I would recommend, my patients after this 1 hour have a very objective view on why and how I could treat them and what I would probably charge. So I hear it every single day when I deal with my patients. They tell me all the same, you're the first one who took so much time to explain me everything. Now I do understand that I need a bone graft. Now I do understand why an implant is better than a bridge, for instance, and so on. So this is very important. Another, you see those little 4 blue balloons on the bottom. So these are just like 4, let's say very little, but very impressive little tools, how to enhance the very subjective attitude of your patients towards your treatment or your clinic. The waiting room. I've seen so many clinics where the news magazines or the papers in the waiting room were like completely old or not, like, I would say aesthetic. So once they enter, the first step they will do after they come to the reception is they go to waiting room. And if the waiting room, you don't need to invest thousands of whatever in your waiting room, but you can make it very easy, nice and clean, and give like an impression that patients are welcome. So this is something that is very important. Number 2, website. I love to go on websites of my colleagues, and I do see so many times the same marketing mistakes, I would say. So what is attracting a patient that does go on our website is not the funny like Apple or the tooth boy or the tooth lady running around or standing around or waving. They want to be kept by emotions. So if you are with your team on the very first slide on a picture taken from a professional photographer, this is attracting. This is attractive. Or a nice face or a nice landscape, something that does nothing to do with teeth, just like a nice emotional capturing picture. We see ourselves and we see our patients too many times out of the box of our dental Googles, which is completely wrong. We would address completely different things that others would do. So that's like something that is so important, that the website is very, very, very professional done, not by us. It should be sent to professionals. I've seen here, one question is if I take money for this 1 hour or if I make it for free. Well, I've tried both. Of course, today I charge. And interestingly, my patients never complain about the fee that they need to pay for this 1 hour, because they do understand if they do go to a lawyer here in Germany and in Switzerland, lawyers are pretty expensive. So if I talk to a lawyer for 1 hour, he will charge me probably 300 or 400 euros. So I tried it not to charge, but I would not say that I would not recommend it. You should charge for it. And it's just like, okay, your very individual rate that you think would be working for a patient, but you should not sell something for free. Who is selling something for free today? Nobody does. Go to your lawyer and ask him for a consultation for free. No, he would never do this. Even the very first minute, he's charging you. So that's something I would definitely not to give it like a giveaway. It's 1 hour. Of course, it's not a compensation for a surgery, but in this hour, I can explain not this treatment, I can explain this treatment. And for sure, because I take my time to explain everything, to answer all the questions my patients have, believe me, I shoot like 95% of my patients when I take 1 hour consultations that I charge. Reception, very important. Very important. The reception is something that's so important. If you try to check out if your reception is working properly, do a fake phone call. Try to be a patient that is like probably obnoxious, and then you can see if your reception is working adequate towards or in a very complicated and challenging situation. Because so many doctors, they don't know that they do lose probably hundreds, probably thousands of patients in a year that they never will see. They lose them not in the treatment room, they lose them at the reception. So words like, let's pretend I'm a receptionist, like, oh no, this is very complicated to make an appointment this week. Oh no, this is very difficult. No, it's intricate. It's a problem. These are no-go words in communication towards our patients, because they would feel like, okay, I don't want to be a problem for you, so I give just another clinic a call or another office a call where I don't have the feeling that I'm a trouble or a problem for you. So you should like change your, let's say, communication behavior and not talk about a problem, but how does it sound like I try my best to figure out what I can do for you. That sounds completely different than, no, we don't have any appointment this week. Sorry, we are fully booked. That's pretty wrong. And of course, staff. Staff is so important because you should like at least once in a week or different, like let's say numbers of employees require probably more often sessions, but you should have like team meetings where you discuss with your staff why you do this, what do you do, and give them like room to make suggestions, just that they feel like that they are completely in. If they are rowing the same boat with you, it is way more easy to convert your treatment plans into execution of your treatment plans, because they spend sometimes so many times more with your patients than you. They do talk to your patients probably more than you do. So if they are 100% convinced about what you do and why you're doing it, then they will be a supplement. They will support you in your daily office and clinic. So I think I came to the end, and I thank you very, very much for those who attended. And just feel free, if you have any questions on mind, you can write us. You can write an email to me, or you go to the DSI Facebook site so they can forward me the questions, and I try to give answers to this. I wish you all from the bottom of my heart the best. Go very well through these very difficult times. It's not only affecting our health, but for sure our economics, and things will be different after Corona. But be positive, take your vitamins, please, and look forward to those times that will hopefully come very soon when we go back to normal again. Thank you so much. Probably we see us soon again when we probably do a repetition or another topic of this webinar. Thank you so much and stay healthy. All the best.